in the world. And that is the mission which Dr. Devi Chetty started an organization to build a company that is able to provide healthcare and affordable surgeries to everyone in India. You have to understand about a country like India is that 80% of all healthcare expenditure are out of pocket, right? And 60% of rural indebtedness can boil down to medical expenses. Right? People borrow money or sell assets to pay for healthcare bills. And this is not a situation that's sustainable. So how long is this going to be an acceptable way of dealing with our healthcare problems? Next slide, please. We have a lot going for us. As a country, India produces the largest number of doctors, nurses, medical technicians. Outside the US, we have the largest number of USFDA drug manufacturing units. We have the capability to produce drugs for the whole world, and in fact we do. We have all that we need to create some example of healthcare for the 21st century. And our goal in it is to bring all these pieces together and create a solution that works for India and hopefully for the rest of the world. Okay, next please. At NH, we've done 1 lakh heart surgeries so far. We have 6,000 beds across 20 schools in India, and we have got 300 full-time doctors. Next slide, please. The one hospital that I'd like to talk about, we have 22 centers, and this is my final slide. It's a very short presentation. The one thing I'd like to talk about is a hospital we built in Mysore. So this is a hospital we tied up with LNB for, and the goal of this was to build a 300-bed super specialty hospital for $6 million. The first time we proposed it to LNB, they said, no, it's impossible to do that. But we insisted and pushed them and changed the way we think about designing hospitals. We use prefabricated structures. Most of the building is in air conditioning, only the clinical areas have air conditioning as well as all the equipment in. The rest of it is just like any other primary healthcare center. And in 6 months, the hospital was commissioned for $6 million. And this is the model we want to replicate across 100 small towns across India. Because the future of healthcare comes from smaller hospitals delivering this level of surgical care. Next slide. This is the end of my talk. I'd just like to end with a quotation from Moses Neal saying, we have never done a small group of things that can change the world. It's the only thing that has. Thank you.
Thank you very much. I'd like to now invite Dr. Kalra, who is going to be focusing more on the status of oral health care in the country and access and affordability in terms of oral health care.
Well, thank you, sir. If I may open up my presentation. That's probably fine. Well, it's a privilege to be invited to this podium, and the reason is that I've done a few things, and I was in a bit of a quandary to come and speak to you, because speaking to me about dentistry when I look at India, I either don't exist, or you only need me when you are in pain. And in between, when you look at 1.26 billion people, and you look at the market forecasts, you look at a roughly $1.2 billion business with an annual growth rate of 13%. And since I've had the opportunity to be on a consulting panel with 3M International and globally, whenever you go out and speak, they say, well, India is the greatest place to be a dentist. I'm probably going to differ a little bit with you, and I'm going to build this case as we go along the lines, because what you look at is that one of the things we've done in the last, say, 50 years is build a tremendous capacity. And we graduate something like 23,000 dentists a year, and you have these glitzy clinics which come up, and all the investment that you look at in the workplace in terms of oral health is purely in big cities like Delhi. And that gives you an illusion of doing extremely well and being extremely profitable. But here's what happens. And when I started looking at oral healthcare spending, and I said, okay, let me look at the emerging markets. And I had the opportunity to lecture in Brazil just about 2 months back. And I'm sorry, Brazil is almost like a European country in terms of the standards of oral healthcare. And just look at the percentage of healthcare spending around the world and look where we are. Well, the richest and the poorest, just look at the figures. I would probably drop Brazil and Russia out of this discussion altogether because they belong to the industrialized world. So here is the truth before you that this is the oral healthcare spending. And that is the analogy that, as I said when I made my opening statement, I either don't exist, I'm not fashionable enough for an NGO to invest in oral health. Please show me. Nobody comes to me unless it's dramatic like cleft palate. But if I say that there is a tremendous healthcare burden that's imposed on this country because of the abject lack of, the distribution and the accessibility of oral healthcare, that's the inequity. I wear 2 hats or turbans, if you permit. I work for Max Healthcare. I provide an $8,000 treatment, which I have takers around the world, and I direct an institute here where I run an outreach program. We serve in a semi-urban and a rural population. We see 600 people a day, and in between, my problem comes in is that nobody wants me. The average person does not even realize what is the implication of a poor quality of oral health. Let me just give you an example of the burden of oral disease, as you might call it. 30 to 40% of cancers, we pick up a lot of cancer here, right here. These are oral cancers. We pick up a lot of precancerous lesions. We are setting up a cancer registry. We don't do a lot of work at preventing it. But trust me, on a national platform, nobody even talks about it, right? I looked at a farmer who loses teeth at the age of 50. He works in the field, he has no teeth, so he changes his nutritional pattern, lands up with a metabolic disease like diabetes, and becomes completely incapacitated, putting a burden on his family. And this is where I stand in terms of oral health care. And when you are looking at marketing, you're looking at affordability, you first need to bring the patient to me. Let me just sort of, I'm going to request Professor Kindra to indulge in me because it's the only opportunity I've got on a podium to speak about healthcare. I've done it on many other things. Just look at this. Let's talk of, what's published in the AHA about periodontal disease and vascular disease. There is a link. We started the sleep clinic. I work on sleep. Sleep medicine. 9.3% of the population of Delhi has serious health hazards because of sleep medicine. We don't even discuss it. And when I come back and I work with the government in different capacities. I'm a consultant to the council. I'm a member of the National Clinical Establishment Council. Well, the annual reports of the Ministry of Health and Family Welfare do not carry a discussion on oral health. It's just not important. Right? The National Oral Health Program dates back to 1998. It's as recent as that. In the recent high-level expert group for universal health coverage in India, there was no discussion on oral health. This is what comes out, that even basics like simple interventions like pain are not available to 70% of the population in this country. And 4 years back, I was asked to answer a question fielded in Parliament, how many docs do you need? And I said the only planning paper we had was an archaic report of the Board Committee, which was constituted in 1936. We've been through 60 years of independence not knowing what to plan. So here is the curious case of dental healthcare. In India, 88% of the population of 1.2 billion have a directly assessed clinical need. We've anchored a very large survey, probably the largest. Go to the Guinness Book. Mrityunjay has worked with me on this. This is what comes out. So this should be, you can see the money coming in, Brilliant. 88% of a population of 1.2 billion have a direct clinically assessed need which requires a dentist. Okay, so what happens? The dentist population ratio hovers at 0.74 per 10,000 against the WHO norm of 1.3 per 10,000. Not too bad because we create something like 23,000 dentists a year. And when you go to the ministry, the bureaucrats just take the number of dentists and they take the population, they divide it, and they give you a figure. But here is my problem. 93% of the population have never visited a dentist. They've never felt the need to visit a dentist. So, when you have a huge latent demand, and the fact that by the time they come to you, you're spending a whole lot of money more on treating people is completely lost. And if I look at investment, public or private, it's focused on creating infrastructure, in building, capacity. And I said the curious case of the missing dentist. From 1973 to 2013, we created 233,740 dentists, right? 58% registered, and out of this 58%, only 40% practice, including the young man who happens to be an army officer who's a dentist, who's doing an MD. There you go, sir. What am I to do with this profession? What am I to market? What do I tell 100 kids who graduate under me every year that, hello, sir, this is where you're headed? And now let's take the next part of the inequity. 68.4% practice in urban areas. In Delhi, you probably have a population dentist ratio of 2.86 to 10,000. And it's 8 times the ratio of the rural area, which is about 0.35. And where do you find all the specialists like me practicing? In places like Delhi. Because that's a national average ratio of 0.11. So, my concern or my challenge to this audience and to people who would be investing money is that there is a high latent field of work is technology dependent. You just cannot sit down on the roadside and say, I want to do dentistry. I need tools in my hand, which is not easy to come by. It's a lopsided resource. There is a surplus in the urban areas. There is a deficiency in the rural areas. Right? There is lack of sustainable earning opportunity. Where is dentistry as a profession today? You come into me and say, I want to admit my daughter or son to use a dentist, and normally talk people out of it. I say, why don't you look for something else? Doesn't work. So, I'm going to sum up here, we need introspection. And when we talk about marketing, what do I need from investment and what do I get to something like this? We're starting a whole new chain of clinics in Delhi, and ladies and gentlemen, what is required here is a massive investment in public awareness. This is going to come out of public-private partnership. It's not going to happen. So anybody who wants to invest in Delhi to create the spiral, to move this up to 1.26 billion people, somebody's going to start telling people you need people. Public health policy has to change. Nobody even talks. I sit on various panels. I have to remind people in the meeting of the National Knowledge Commission that, excuse me, sir, can I say a few words? You all discussed the health of India. Do you think I'm important? It's actually happening. People have a laugh every time they see me. So, this is what you need to see, rural extension services. And that's where the money is. So, if any one of you is to come back and tell me, especially my friends from overseas, are going to invest money, then I'm going to suggest something like this, that this is the last project I did for the Army, they introduced it. We took primary and secondary healthcare right up to the point where the troops were deployed. I had to do a big study. You need to look at insurance. I've tried to talk to people. 80% of the expenditure comes from personal funding. It just doesn't work. So we need to change the mindset. If I have to make this profession work, then I need awareness, I need accessibility, and finally I'll talk about affordability, as the chairperson would say. So I'm going to leave this to you with a few thoughts and come back to me if I can elaborate upon any or all of these issues. Thank you so much.
Thank you. I've certainly learned a thing or two about dental healthcare. Let's continue with Dr. Mathur, who's going to focus a little bit more. I think his presentation is going to be touching more upon use of technology in affordable healthcare, or at least I assume so. Thank you.
Yeah, good evening. So, I think the many things common in my presentation and the problems of blindness as in dentistry But we are a little more fortunate. I think blindness attracts a lot of emotion.
A lot of emotion.
And India was actually the first country in the world to have a national blindness program. So we do get a lot of support. So this hospital is in the heart of Delhi in Daryaganj. It's nearly 100 years old in a heritage building. And has a glorious past of Mahatma Gandhi, Rajendra Prasad, the first president of India, having been there as patients or as visitors. However, like what happens with a number of institutions, it was a pure charity organization, and it had a slow decline with failure to keep pace with advanced technologies, losing focus on quality, attitude of staff, and it was on the verge of closing down or being given to the municipal corporation to run. In 1996, a corporate group, Aisha, supported the hospital, and we've basically been working from then on. And our mission is to make a lasting impact on the eradication of blindness and deafness in India by providing quality care to all sections of the society. So what we've focused on, and I'll show this as an example of how we've tried to take sustainable and an affordable eye care to the masses. A big focus went on quality. In India and in a lot of developing world, botched cataract surgery is one of the leading causes of blindness. Only 60% of people who undergo cataract surgery get good vision. So there was a need to improve infrastructure, technology, skill upgradation, and most importantly, best practices. And what does quality lead to? Satisfied patients and good medical outcomes. And to work further on it, we went and got the accreditation, the NAPH, and this was the first hospital, although it's a charity hospital, one of the first hospitals in North India to get this. And importantly, charity does not mean second-rate quality, and that's extremely important. And that has led to, like the former president of India comes to our hospital to get his cataract surgery, and we take pride in the fact that we take care of the penniless and the former president. And with that, the number of surgeries has increased steadily. At the same time, we maintain at least 50% of the work that we do is free of cost to the patient. So we do a little over 15,000 surgeries is what we did last year. We work on a cross-subsidy model. So the patients who can pay a fee for their procedure, and that overall improves the quality of service. When you have to work and compete with all the boutique clinics of Delhi, we have to stand up and meet that quality, and that rubs off. And interestingly, we don't make that choice. The patient walks in and can decide which category to go on. There are small cosmetic differences, but essentially the medical system remains the same, the operation theatre remains the same, it's just the patient chooses which way to go. We generate the demand by creating value for patients. The quality of care, medical outcomes, skill is what attracts patients, and also you have to work with all the different agencies that way. Importantly, we have to keep an eye on the costs. We use a lot of locally sourced consumables, and India is actually very good at that. Across the developing world, it's Indian consumables being used. In 1990s, when I was getting trained, an intraocular lens that we implant in the eye used to be imported. In those days, it used to cost $100. And they were all from these Japanese or American companies. They wouldn't bring the cost down. And it was an elitist surgery to get an intraocular lens. Till the companies down south started making it, and the cost came down to less than $3. And today, the cost of cataract surgery in India, the consumable cost is only about 600 rupees. A basic cataract surgery. Some of the things that we work on, we are all full-timers. We are all on salary. There is no fee for if you have staff that is salaried. We work on very high volume, and that helps in reducing the fixed costs. So economies of scale bring down the costs. The other important thing is task shifting, or to improve productivity. A doctor should be doing only what a doctor should. What can be done by a technician should be trained to do. And we train a lot of local staff. By doing 50%, a little over 50% work free, we meet a little over 90% of our running expenses. And that's somehow been constant for the last few years. Now, one of the reasons we mentioned was the cost of healthcare that the patients don't access it. But I feel it's not just the money, it's also lack of eye care facilities and also the fear of bad surgeries that people don't access health, and that may be true for eye and other disorders as well. So we have this model, what we call as the eye care pyramid, where at the base we provide primary eye care at a vision center where we train a person who's out of class 12 for 1 year in refraction, pressure check, a basic eye examination to know things like cataract or glaucoma, and they also dispense spectacles. This is at a primary eye care, and then we provide a small infrastructure and build a clinic which runs 24/7 in a rural area or in an urban slum. This is how a typical vision center is. This is in a slum of Delhi. This is supported by a secondary hospital, which is a hospital where there's a doctor, either one doctor or two doctors, and we do basic surgeries like cataract there. And about 2,500 surgeries per year is done at these secondary hospitals. This is one of our centers in central UP, and that's our very first patient who very sweetly goes home on a bicycle after her surgery. So this is how we run it. We have the tertiary hospital in Delhi and Daryaganj. We have 3 secondary hospitals and 15 vision centers. Hopefully we'll have 30 very soon. In an Indian scenario, especially in health, we doctors love technology. It's like we love our new mobile phones and things that we also are always asking for the latest and the newest. But you have to be careful with the technology. You have to use appropriate technology. A manual small incision cataract surgery is also very safe as compared to the very small phacoemulsion. But this is cheap. It does not require technology, has good follow-up. The technology is also useful because that generates demand for patients who can afford to pay and helps us in sustainability. Even in remote locations like central UP, we have about 25 to 30% patients who can pay for their service, and that is useful. We generate demand by doing the outreach programs, and the high volume makes the doctors very proficient. You can have a number of doctors who do very high volume surgery. The other thing we worked on was working on improving the human resource, and not just the doctors, the paramedics, the vision technicians, ophthalmic nursing assistants, optometrists, and they are the backbone of our service. We also train ophthalmologists. I don't know whether a lot of you are aware, a lot of the post-graduation teaching programs have deteriorated in the last few years, and a lot of doctors who are coming out actually do not. There's a hospital just a few kilometers from here, private medical school, where doctors get trained without doing a single surgery. So there is a need to train these doctors as well. While they're getting trained, they serve the people. So a lot of our doctors, once they've got basic training, also go as part of their training to some of our secondary hospital and get trained. And they perform surgery there. Of course, under supervision. This adds to our workforce and reduces our costs. And not just doctors, the paramedics as well. Of course, the road ahead, the challenges of scale, and we know we've gone some distance, but I think we're just there. A lot needs to be done. Some of the challenges that we face are of human resource. If you look at the doctor population ratio in India, it's 0.78 per thousand, while in the US it will be like 3.5 per thousand. But surprise, surprise, the nurses ratio is even worse. It's 0.58 per thousand. 73 out of 593 districts in India do not have a single registered nurse. If you look at eye care again, the paramedics, the optometrists and vision technicians are only equal to that of doctors, while you should have a ratio of 1:5. So is our healthcare too doctor focused? And even as I speak today in the morning, the whole newspaper is about doubling the number of seats in medical colleges, but very little focus on paramedics and trained paramedics. And so it's important to develop these trained teams. It's not just the doctors. You need to train eye care professionals, reach out to larger population, improve outcomes, and only then will you have very satisfied patients. A lot of this can be done through local resource in rural areas, semi-urban areas. You can train local people to do very specific tasks like refraction or pressure checks, and I'm sure that's possible across healthcare. Of course, there's a problem of having enough trainers, and we haven't found very good answers as yet for it. Creating access to eye care, the need is limitless of these services. Our model seems to be working, but finding doctors for secondary hospital has been a challenge. The quality of life in those towns or rural areas, professional growth, financial growth, it's been a challenge to find steady doctors to run these hospitals, and it's still been a struggle to get stable doctors there. The third challenge is of operational surplus. Although the slide is nice, 50% you're doing free and you meet 90% of your running expense, but you do not have surplus for your growth. And on the paid side, there's a lot of competition from corporate, for-profit clinics. Hiring and retaining skilled manpower is a challenge. Technology upgradation, infrastructure upgradation, all require you to have surplus. We do get a lot of support and donations and philanthropic support and projects, but not at the pace you like. And they have a big gestation period. So in conclusion, as a country, we need to be cost conscious. The healthcare delivery system should aspire to cover as large populations as it can, promote affordable healthcare institutions that provide quality care across all economic sections. Economic development seen over the years can pull people from poverty, but health issues, as we've been discussing, can take them back. Thank you.
Thank you. Would you all now join me in welcoming a gentleman to my right, Mr. D.R. Mehta, who's going to be speaking about the Jaipur Foot project.
You will have to do it. And I say start. Please do that. Thank you very much for this opportunity. It has been my privilege that I am part of the Jaipur Foot team. Started with a personal trauma. I was born on a hospital bed. Started in a very small way. And today it provides over 60,000 aids and appliances, almost 24,000 odd limbs to the disabled in a year. By now we have covered, or we have rehabilitated more than 1.4, along with almost equal to 1.4 million disabled. What I suggest is, I go with the visual presentation first, and then I will make some comments. Please. Start. Good. Good. Keep on moving. Good. These are our products. Good. As I told you, this is the figure up to 31st March 2013. Now it's 1.4 almost million beneficiaries, which 0.5 million are employees. Would you believe that in the entire city of Delhi, I'm making a comment which is not very polite, not even 400 limbs are fitted in a year. Would you believe that nobody in the world can fit even 1,000 limbs a year? Every year we are fitting about 20 to 25,000 limbs a year and about 15,000 odd calipers a year. Of course, no new cases of polio or old cases persist, then other kitchen appliances. And our technology is Jaipur technology. It started with a medical college. It was developed there. I was not associated, our society was not associated there. But they could not fit even 50 limbs in 7 years. 68 we set up. In 75 the society was set up. Bhagwan Mahavir Vikram Sahayata Committee. In the first 7 years of the society's existence, 10,000 limbs. Now over between 20 to 25,000 limbs a year. So that's the kind of volume of scaling up. Then mainly works in India, from Kashmir to Kerala and from Gujarat to Assam. Out of 529, out of say 621 districts of India, we in a year get patients from about 530 districts. Then we had camps in, now it's 51 camps in 27 countries. Mauritius camp was completed only a few days back. 4 camps we had in Afghanistan, 2 in Pakistan, Iraq. Now, I'll come to that later. And then the most important thing is totally free of charge. So, go ahead. And functionally, Mr. Sharaf made a very interesting point, that charity does not mean second-rate quality. A person with below knee, Jaipur limb, can walk, sit, squat, run, swing, climb a tree, mountain, ride a bicycle, drive a car. And well, let's see this Japanese food. He gets a limb in a day or two, but he runs, climbs a tree, rides a bicycle, the bilateral amputee, gets the limb, walks, skating. This boy, he runs half marathon, 21 kilometers in Mumbai every year. Last 10 years he has been doing it. This is Sudha Chandran, famous actress. Yeah. She is our brand ambassador. He rides a car, drives a car. He rides a temple. Now this is, our cost is $50. That's the cost to us. As I said, we are providing everything totally free of charge. The cost of a comparable limb in the US is $10,000. Now people ask us, why is their cost so high? I said, ask them. And these are not my figures, mind you. C.K. Prahlad, one of the most famous management gurus, after Peter Drucker, I think he was rated as almost at that level. He visited us, observed everything. We came, about 115 people sitting there, disabled. I said, you pick 10. He did. In 4 hours, limbs were made, and his wife delivered those limbs to those people. His story, he wrote his famous book, Fortune at the Bottom of the Pyramid, in which he devoted a full chapter on us. And there he said, those of course were the figures of 2002, that our cost that time was $30. Now it's 50 in 12 years, this is the increase. And the cost in America at that time, he said comparable limb in America would cost $8,000. Now it's $10,000. So we are talking affordability. And here of course totally free. Even if we were to charge, we would be charging only 250 rupees, 2,500 rupees. Correct. Now, we take special pride in saying that somehow so happened that we got connected with some of the topmost technology institutions of the world. Mr. Chairman, you were asking this about the innovation and research. Stanford University, and mind you, we did not approach them. They came, said, we would like to work. Stanford, entire Silicon Valley is based on their researches. MIT, in MIT and Stanford, at any point in time you go, you may find at least 10 or 15 Nobel laureates. Those are the kinds of universities they are helping us. In Stanford University, we developed a new 4-bar linkage polycentric new joint called, we call it Stanford Jeopardy because we want to take advantage of their brand. They say call it Jeopardy. And what does Time magazine say on this? Please go ahead. It says that it is one of this Jeopardy needed for the above knee patients. It's not for knee replacement. People have lost limb altogether. Is one of the 50 best inventions of the world for the year 2009. Name one Indian product, a joint Indian product, which is so rated. And we already fitted more than 6,000 such joints. The interesting part is, as it is the best knee joint available in the world, and the updated version of this has recently been received, and an Indo-American Foundation has given us $200,000 to test 500 such joints in next one year and a half. Right? This same thing, Time magazine, and the 50 best inventions. Yeah. Now it says that this is a $20 knee joint. And Time magazine says not me. Says that a comparable knee joint in America, made of titanium, therefore heavier, we make it out of nylon 6, oil impregnated nylon 6. Cost $10,000. Please go ahead. Now Stanford is making Jaipur hand. I'm expecting the team with the revised version of the prototype in this place in Jaipur in February. Etc. They use polymers. So they gave us a design. He made the foot pieces. Excellent foot pieces, but longevity was not much. Now MIT, Dow Chemicals, International, Mahavir Viklang World Society, and one more company. They're working on it. And if this succeeds, it's injection molded. It would even replace Jaipur foot. It would be lighter, cheaper. As you said, as I said, as you saw, so therefore today, foot piece only cost $10. This might cost $5. Go ahead. Now then we set up a gate lab. It is the latest gate lab in the country. And incidentally, of course, we are too small and pretty angry. But the same software is available to NASA. We have that link incidentally. Please go ahead. Of course, that's separate. Now, so this is the kind of work which is being done. We are not doing marketing in the normal sense. When we do marketing, we do it for getting some data. Here it's all free. And free why? And I'll give you why we are doing it. The government is the largest provider of health services in the developing world. And many good institutions exist. One of the finest institutions I have seen is no other private institution can match. The Tata Memorial Cancer Hospital. But generally, the quality, efficiency, speed, etc. are not there to satisfy the patients. Therefore, you have the alternative models. What are the alternative models? One is ultra-charged models, 5-star hospitals. They are needed. Those who can afford, why not? Of course, they have generated a lot of money. They can also buy latest equipment. I'm not against that. In fact, if I call them, I'm glad to go forward. The reasonable charge models health services. Now, there are many hospitals. Narayan Padale is, for example, one. But still there is some element my information is correct. These are also, they take care of the second segment. Third is reasonable charge model of healthcare without the element of profit. So you have to have different kinds of institutions. We have a very eminent professor of marketing of Petrol School of Management. So I learned that lesson. Third category where the cost is even lower. Fourth is low charge model of the healthcare. We fall in that category. Fifth is the mixed charge model. Now, Dr. Sharaf mentioned that patients are given the choice. Very good idea. You may on this side of the line or that side of the line. You get to say that this Arvind Mitra again is the same model. So these are the kinds of models, but we fall in this kind of category. And why? Because you know the disabled in India is among the most disadvantaged person on earth. He lost his mobility. Because of that, he can't earn his earning. Now many people argue with us, we get almost 1,000 people from all over the world every year. Almost 700-800 people to Western world to see this model. They say, you must charge at least something. And they buy. Because if you don't charge, people don't appreciate the importance of the thing you are giving them. I said, please understand, we are not in the game of seeking appreciation. We are there because of inner satisfaction. Secondly, don't make money the measure of everything in life. And thirdly, I said, you see these patients. If I announce that 10% of 2,500, that's 250 rupees I am charged, by the evening, the entire building will be empty. They don't have that much of money. So just because they don't have the money, should they evade the price of their basic need? That is a lack. So we decided. The next question, how are you sustainable? So model has to be both sustainable, affordable and sustainable. Now I have some financial background. I worked in the government, in the finance ministry, and worked in the Reserve Bank of India and SEBI, and almost half my life I spent I mean, I often confuse people. When I say I worked in the government, they say I worked in this field then. So we started right from day one with a corpus, small corpus. Work increased, people came, saw, people see this kind of work, they can donate money. And we also know the psychology of the donors all over the world. Once they see the work, when they are satisfied about the credibility of the institution and the quality of the services provided, you will get money. The professor of Cornell University studied us. He said, Mr. Mehta, sorry, you are not sustainable. I said, I accept it. Money is a hard reality. You have to have it to run the institution. But I said, Professor, let me talk to you in a lighter way. Professor of Cornell. I said, you are an eminent management guru. You must have had a large number of Fortune 500 companies with your great advice. Tell me how many of them survived. This was in 2007. By that time you were 32 years old. Now you are 39 years old. I said, how many of the companies which you gave your advice to survived for 32 years? Who is more sustainable there? Then I said, I am not a pure rational being. Try to be rational. Also have some faith and all that. I said, my belief is that if your work is proper, without any dishonesty, and such some visible impact, there are compassionate people in the world. I said, let me have the audacity of having a parody of Einstein's famous equation E equal to mc square. I said, E for me is not energy, therefore M is money. C is not speed of light squared, but compassion squared. And let me add, and G is God. So long as you do work properly, He would not let you go down the drain. So my point is, and believe me, our expenditure is over $3 billion today, despite the fact that our costs are so low. C.K. Prahlad would often say, he mentioned this in Davos, he told me, he was invited as one of the principal speakers. And what he said was, in Davos, mind you, what has Jeffrey Food to do in Davos? He said, if you calculate their cost in terms of American standards, the work they do is worth $6 million US. But even $3 billion to raise, every year. So we created a corpus, partly that generates some income. We get some support from the government, 15-20%. And rest is all donation. And when people come, a lady came from England, a famous institution. He saw, she cried for 3 minutes. I have never seen a British lady crying publicly. So self-composed. And she said, that we'll give you £1 million. And next 2 months I got that. So, submission I have to make is that for any project of this kind, the first way these kinds of projects are needed. Otherwise you are not taking care of a large section of the community. Healthcare does not mean healthcare only for the rich. Very often we make this mistake. And healthcare does not mean that it must be always costly for quality. This is a very wrong kind of an impression. If we can do it, if this joint, Time magazine says this, I'm asking you, name 3 Indian products, industrial and manufactured, I'm not talking yoga or music, the brands of which are known all over the world, you are all management experts. Name 3. I mentioned this to Mr. Montek Singh Ahluwalia. He had worked together, he was finance secretary in our chairman Sebi. He scratched his head. He said, Jaipur food is one. And then the second, then I told him, I said, Ratan Tata went to see President Obama. And before that, we were talking to Mr. Anish Sharda. He's the director of research and development. Obama administration. And he put this question to Ratan Tata. And he said, they were put in London. They name any other product. Then which quality you are talking about? And then the other thing is, very important critical factor is, and I'll conclude with that this tendency, I mean, yes, if you have to have growth, you have to have surpluses, you have to have charges, or you get donations, some financing arrangement you have to have. It does not mean that you would charge. Case of Novartis, you know? Novartis, generic medicine they made, they're making it for 8,000 rupees. That included the markup. And the same medicine made by Novartis was costing a cancer patient, poor cancer patient, 1,08,000 rupees a month. I think there's a need for reforming the healthcare system. It's time. People will not let this happen. I mean, just as example, I mean, in India, some of the companies are selling these limbs. 1 lakh, 50,000, 3 lakhs, 4 lakhs. Why? And how much time they take? 3 months. We do it in 1 or 3 days. And I asked them, I said, if you think that our quality is poor, do one thing. Appoint a judge, 2 other people whom you have the confidence. Bring 10 people of your side. I'll send 10 people on my side. And make them do these things. Stand, walk without stick on the undulated ground, run, squat, swim, ride a cycle, drive a car, climb a tree. And you see who does it. You know, in the Western design of $10,000, they have this dorsiflexion, this self-foot. Now that does not have dorsiflexion, movement at the ankle. So they can't even squat. Now just think of this. In India, 52% of the population does not have toilets. This is the latest census figure. And if you don't have the flexion at the ankle, how does one defecate or urinate? Entire weight comes on one leg if you don't have a commode. And how many people in India have commodes? 52% don't have anything. Just finish it. Just so 52% people. Now if you don't have this kind, if you don't address this and you say your quality is good, it does not even address the basic needs of the people. A Muslim can't perform namaz with that thing. My submission is, when you talk of quality, you must consider whether it's satisfying the need of the people. And secondly, you also must consider that is it ethical to have such high rates? That is not marketing. In company's terms, yes, it may be marketing, but it's not real. Thank you very much.
Thank you. Well, we have heard about promotion, the importance of promotion in healthcare. We have heard about training in healthcare. We have heard about compassion and passion in provision of healthcare and as a model, quality and money flows. As you heard, donors come to you. Money is never a shortage. That's an interesting business model to consider. Now, I personally do have a lot of questions and comments, but I'm going to refrain in the interest of time, and I think also some of those might come up in the audience interaction with the presenters. So without further ado, we'll open the floor for questions.
We talked a lot about insurance as a promise that, once insurance penetrates, more people can afford healthcare. So I wish to know from the panel, is insurance a big promise for affordable healthcare in the future in India?
As of now, it's a very small percentage, and I think it's restricted to the larger cities. The government does have an insurance scheme called the RSBY, the Rashtriya Swasthya Bima Yojana. It is interesting. I mean, I think it's still very new and the implementation is still not very good, but it's quite paperless. The patient has to just put a thumb impression, and the providers and even the private hospitals can provide that. They just put their thumb on a pad and the picture and everything gets loaded, and it's quite paperless. The problem is very often, as of now, the server is down and the implementation and everything is a problem. But it does hold promise. But where are the providers for that service? So there are not enough providers, I think.
Right. If I may come in. Please. A little while back, we got into the act of looking at insurance for old health. I was interested in enlarging the scope. Mrityunjay sitting here, we discussed it, and straight away, the person that you're dealing with comes in and says that you've got to get me insured business of say 100,000 people who would pay me X amount of money to get this model to work. So here's my take on this: that unless there is a public initiative and some kind of governmental agency gets involved into ensuring the common man, this is going to be a privilege of the rich and the few, who are in any case served in any way. So I really don't see this percolating down unless we can create public initiative on insurance.
A very brief comment I make. I agree with my friends. But one additional point I submit. In US, which is the richest country in the world, 26% of the population cannot afford the insurance premium. And therefore they do not get the normal health care at all. So insurance is a good thing, provided the premium is not high. And as he rightly said, it's spread all over the country.
Now, Mr. Shetty, would you like to add to that? Because I think your organization does have a model that essentially works in the same direction.
Yeah. So the problem with insurance is, yes, just like in the US case, the premiums are too high and it's not accessible to a large part of the people working in India. So we tied up with the government of Karnataka and launched what we call Yashaswini Micro Health Insurance. And what we did is we tied up with the cooperative societies, with the Karnataka Milk Cooperative Fund. And for a tiny premium, it was started at 5 rupees per person per month. But every member of the cooperative has to be a part of the scheme. So we enrolled 1.2 million farmers into the scheme, and that covers the cost of surgeries and hospitalization stay. Since then, we've it's expanded to 2.5 million farmers across Karnataka, and a sister scheme has been rolled out in Tamil Nadu called Kananga scheme. It's rolled out in Hyderabad called Arogya Raksha, and starting out in Maharashtra. So the future of insurance is not, the classic model where you go to insurance company and you get a checkup and then they determine the premiums based on that. The future of insurance for a country like India is one where we utilize the fact that we have just so many people. We collect a tiny amount from everyone, but we collect it from the large population and subsidize the cost of complicated surgeries, sorry.
Thank you.
Yeah, I have a question. I have heard in your heart hospital, you have achieved in reducing costs a lot. Which are the areas in which you have managed to reduce costs and other big hospitals can't do it?
I'm sorry?
The areas, I've heard that you have succeeded in reducing costs. Which are the broad areas where you have achieved reduction in costs?
We started out with cardiac care 13 years ago, but since then we are in cancer care, we're in all multi-specialty, in nephrology, neurology, orthopedics, general surgery. Apart from cardiac, we run the largest dialysis network in the country, and we managed to bring down the price of per dialysis case from 3,000 rupees to 800 rupees. So that we just use the scale as a way of bringing down costs. Because you have to understand that 30% expenses disposables on drugs, on medical equipment, and the more volume you have, the more you're able to bring down the cost there.
Any more questions?
I'd just make a quick comment. One of the concepts of affordable healthcare is hinging on the lean concept. That you take all the frills away and you come down to just the basic diagnostics and the basic procedure. And the comment that was made earlier by none other than Mr. Mehta is that when you work for a corporate healthcare, the effort usually is to see that how many diagnostics can you do for a patient. You enlarge it. So truthfully, you really need about 50% of what is actually being done, and that only happens in a setting like what Mr. Mehta supports, or if you were to come to us and look at us looking at 500 people who come in from the villages. So we work on a lean principle, and I think this is a model which is beginning to take hold of healthcare if you have to make it affordable. You really have to peel off the layers of the onion and look at the core. It's possible.
One last question, please, because we are short of time. Yeah, people are waiting at the auditorium.
Just a quick question.
Yeah, one last question.
Yeah, thank you.
My question to you is that when we talk about healthcare, how do we segment people who are needy? Because I know I just have an experience. I have seen AIMS when we talk about cancer. Now in AIMS there is a huge queue of people sitting, and the doctors are not accessible. Even if we talk about specific cancer hospitals like Rajiv Gandhi or Tata Memorial, they have specific days to deal with the poor and needy. What about the middle segment, people like us? One question is this. Second question, when you talk about healthcare, doctors, these are the people who we look up to, because when you talk about healthcare, because it's a service industry. Now there is again a lot of competition is happening, a lot of private players are coming, global players are coming, and a lot of doctors are moving towards that. The doctor who was working in Rajiv Gandhi has gone to another multi-speciality hospital. So what is your take on that? So these questions, these two.
Trust them.
Yeah, I would agree. I would agree. You leave it to the patients; they know what to decide. And that's been our experience also. You can offer the 5-star facility, and you can offer basic facilities. Patients are smart enough to choose. Like I said, we have all the sliding scale, but maybe it's only about 10% patients. We sometimes feel, he's sitting with a laptop and everything, and while on the non-paying side. But on the contrary, we have 10% patients. After we examine the patient, we really feel sad. Why did he have to pay that 500 rupee fee? He doesn't have money to buy the medicines, and we have to get the thing waived off. So it's both sides. So maybe only 10%. The rest choose for themselves.
Coming to cancer, since I have a tie-up with at least 3 hospitals and we do a lot of oral cancer, truthfully, I think the institutions are overburdened. And the commercial establishments, and I don't hesitate to say commercial, although I'm associated with Max, it's not a paying proposition to have an oncology patient. You know the patient is going to die, you're going to have a whole set of people crying on your doorstep. So people are actually told that, why don't you go to Rajiv Gandhi or go somewhere else? So it's a very sad...
I don't agree with you. I've been a patient and I'm sitting right
now. You're lucky, but I'm just trying to tell you that you asked me a question about the majority. Let me tell you that people are turned away. People come back to us because we refer people to hospitals. They come back to us and say that, can you send me somewhere where it works? So essentially we need a serious initiative from the ground to create institutions where people would be taken care of. My first thought is you're creating 10,000 more doctors. Have you thought what you're going to do with them? That's my issue.
All right. Thank you very much. Mr. Mehta has requested 30 minutes of it.
Just 30 seconds, 5 minutes. I already took too much of time. This kind of healthcare model which has been created around Jaipur Fort is attracting a lot of attention. Harvard Business School has recently written a case study on it. That was on the 4th of November 2013. And in fact, they invited me to give a talk on that on the 15th of February. Then I am Ahmedabad did a story long time back, and I am Bangalore has done a case study recently. So that's another. I thought I'll mention this to you because, and C.K. Pradal I already told you. So the people are in search of some models which can work for a certain segment of the population. Thank you.
So on that note, thank you very much, the illustrious panel, and indeed thank you all, the audience, for being so patient. Thank you.
I'd like to thank you everybody, and in the end I'll just say one line: healthcare will be where we'll all collectively take it. So it's going to be a collective effort of everybody. We're going to build a better society if we just pay more attention to these things. Thank you very much, and I would like to request you all to proceed for the auditorium. There is a 10 minutes break for the snacks. Before that, I would like to thank everybody. I would like to call Professor Maiti to the stage. As a token of appreciation, we would like to thank everybody.
Mr. Mehta is also going to leave some promotional materials on the table in the front, so if anyone is interested, please help yourself.
Thank you, Dr. Mathu. Dr. Bala. Thank you so much, sir. Yeah, we can send them across. Yeah, that will do.